Thank you so much, Dr. Deepankada, and thank you, Izzy Eco. So, as I was told that I have to stick on time, and I have been given 35 minutes, so I have only 35 slides. So it's going to be very, so we'll be finished on time. So I've been given a case, and so this is a 72, so let's try to make it more interactive. So a 72 years old female, she presented with new onset angina on exertion. She was an ex-smoker, hypertensive diabetic with CKD. Echo showed an LV hypertrophy. These are the measurements with normal LV dimensions. EF was preserved. There was no regional wall motion abnormality. She had a thickened calcified aortic valve with a gradient of 54, peak and a mean of 34, with an aortic valve area of 1 by continuity equation. She has severe MAC. So the questions was, what are the further quantification for aortic stenosis by echo or any other modality? What is the importance of MAC in this group of patient, and what are the problems of effort angina? What are the causes, and how do you manage this? So this was sent to me almost 2 weeks back. So this patient has aortic valve problem and also a mitral valve degenerative problem. So before I kickstart, for everybody, MAC is a problem, and there has been a grading of MAC, which is called mitral annular calcification. It is a degenerative problem, and the grading in one of the reports, they divide MAC into mild, moderate, severe. So I just thought that this can be a teaching thing. So whenever we see the mitral valve in parasternal short axis view, so if there is a focal dot of calcium involving the posterior leaflet, posterior commissure, this is mild. If it involves the whole of the posterior PML, it is severe, and anything in between is moderate. And this is on 2D. And if the AML is getting involved, most of the time it is always with PML, so you will have a severe MAC. So this is the way you can classify mild, moderate, and severe MAC. The important to differentiate MAC from rheumatic MS is that the gradients in rheumatic MS are high to cause symptoms, while gradients in degenerative mitral stenosis because of MAC are relatively low to give you symptoms. And it is very important that this entity should be identified. The reason being that these patients generally get symptomatic with lower gradients, and as you can see that if the gradients are higher in degenerative mitral stenosis, the prognosis becomes poorer. So this has to be identified. This is a basis of this case. So I tried to find out a similar case. So this was a similar presentation of a patient. So she was 69, NYHA class 2 symptoms, had chest pains on exertion since 10 days prior to admission. These were the vitals. The BMI was 26, body surface was 1.7. She had a systolic murmur. She had some evidence of nephropathic, 1.8 creatinine. NT-proBNP was elevated, normal being less than 125. So this was a similar case I could identify. So these are the echo images. And as you can see, is it visible? Yeah, okay. Very poor window of the echo. You can see there was a good LV function looking. There was some evidence of calcium deposit both at the aortic valve and the mitral valve, and predominant the aortomitral continuity. So this is where the calcium generally starts depositing in this patient. So she had 1.8 creatinine. And when we looked at the flow, there was some turbulence in the forward flow. So we were dealing with aortic valve problem. We were dealing with calcified mitral valve problem. The interventricular septum was thick. The posterior segment was around 10 mm. Couple of more images. The LV ejection fraction by biplane Simpson was preserved. It was around 61%. Remember, we should not report ejection fraction by M mode. We still keep on getting M mode by TCOX formula to get a EF. We should not be doing it. And the LV strain was around minus 11.7. So it was reduced. Now, remember, look at the pattern. This strain analysis in a patient of aortic valve and a mitral valve calcification is important because now we are going into an era of structural heart disease, and I will tell you why this is important when I move into the slides. So this patient was an elderly. She had chest pain, breathlessness on exertion. Creatinine was 1.8. Aortic valve was thick. Some turbulence. EF was preserved. Mitral valve was thick. Moving ahead, more images. The images are not that good because she was an obese lady. So we got more information. The LVOT is 1.9 in the phase of mid-systole, and the LVOT VTI was 19.5. Now, why this is important? Whenever we are getting a patient of aortic stenosis, we have to identify and look for the stroke volume, because stroke volume and stroke volume index is an important entity we have to identify. So stroke volume index in this patient was 32.5 ml. You have to remember these values, and I'm also looking at the ejection time. Ejection time is nothing but the time from this point to this point. You can look at it, and this was around 0.4 seconds. So I just want to give you an idea that whenever you're measuring LVOT, we now try to go for a biplane imaging and try to look at the LVOT in parasternal short axis view also, and you can measure at this. But at this point, the LVOT was 1.9 and the stroke volume index was 32.5. Moving on to more images. So to brief up, the aortic stenosis is classified, everybody knows, as mild, moderate, severe, one being less than one being severe. More images. This was the CW across the aortic valve. The peak gradient was 58, the mean gradient was 36, and the aortic valve VTI was 75.4. So these are the measurements which are very much needed. So on continuing equation, the aortic valve area for our patient was 0.73. The case which was given was around 1. So this was a patient of severe aortic stenosis. Now, what does the information shows? That there is something called severe AS and there is something called very severe AS. And these are the various parameters. If the mean is more than 40 or more than 60, it is severe AS or very severe AS. But we were dealing with a mean of 34. So is it but the aortic valve area was less than 1. So we are having somewhere here. Right? So there was a discordance in the aortic valve measurement between aortic stenosis by continuity equation measurement and the stroke volume index, which was not. So what is this condition? So let's move ahead. So understand that there are few caveats in the continuity equation measurement, because this occurs in a day-to-day practice, and we have to identify this, that you need multiple measurements for looking at the continuity equation, and the aortic valve area calculated by this is widely used as a less flow dependent method that can be applied to assess aortic stenosis even in low flow status. But aortic valve area can be prone for measurement errors because of LVOT. So LVOT area assessment can be very different, and there can be inter-observer variability. So we have some robust parameter, which is the dimensionless index, which can be incorporated, and this can be used in various settings. So let's look at what is a dimensionless index. It is defined as nothing but LVOT VTI divided by aortic valve VTI, and anything less than 0.25 is severe aortic stenosis. Very helpful in atrial fibrillation prosthetic valve. So in our patient, the dimensionless index was 0.258. So it was hinting towards severe aortic stenosis. But how do you classify the grading on aortic stenosis? So anybody who has a dimension less than 0.25 goes in the severe morphology. So this adds up to the information of grading aortic stenosis severity. But there is more to it. Remember that 40% of severe AS patient can have discordance between peak and mean velocity. And this discordant grading creates a subset of entity which I think you must have heard about. And these are basically called patients of classical low flow, low gradient aortic stenosis where the ejection fraction is less than 50%. So you will have stroke volume index less than 35, you will have EF less than 50, and you will also have a low gradient. So low gradient means less than 40 mm mean gradient. But there are two other entities which is called paradoxical low flow, low gradient, where the stroke volume index is less than 35, the EF is preserved, but the gradient is mean gradient is less than 40, and you have a normal flow, low gradient. But let me simplify this terminology by this entity. So if you have a patient who has severe AS, but a preserved LV ejection fraction, you can have high flow, high gradient. That means the mean gradient is more than 40, stroke volume index is more than 35. Fantastic. This is very easy to identify. You can also have a low flow, high gradient. So flow is defined by stroke volume index, while the gradient is 40. This is another entity. But you can also have a high flow, low gradient, which is gradient less than 40, but the stroke volume is preserved, and a paradoxical low flow status where the EF is preserved, but both the things are reduced. Now, why this is important? Because the behavior of these patients, if not treated, differs. And this is one of the works which have been published. Of course, a lot of literature has come on. So the worst is patients who have a low flow, low gradient. You can see the survival to death and survival to death under management. This is the worst with low flow, low gradient. So this is very important to be identified, and this has to be picked up in every patient. And I can roughly tell you the approach that if you are diagnosing severe ES, identify the mean gradient. If it is more than 40, you are looking at a high gradient severe ES. If it is less than 40, it is low gradient severe ES. Look at the EF. If EF is reduced, it's a classical low flow, low gradient. If the EF is preserved, look at the stroke volume index. You have to look at stroke volume, always index it to body surface area. And the key is 35, and you get this entity. So this is a very one of the way of approaching a patient of aortic stenosis who are coming with severe aortic valve problem, and you can have a prognosis of this kind of patients. Now I'm just trying to make it simple because aortic stenosis is a very interesting topic, but a lot of things are mentioned. There is something called aortic flow rate. I'm just mentioning it. You have to understand that it is nothing but a ratio of stroke volume, which is not indexed. Stroke volume divided by ejection time. The stroke volume divided by ejection time gives you aortic flow rate. And if you have severe aortic stenosis with a mean gradient of more than 40, you are surely dealing with severe aortic stenosis. But if the mean gradient is less than 40, if you look at this aortic flow rate, at rest, if it is less than 210, then there is some problem with your aortic valve area assessment. But if it is more than 210, you are surely dealing with severe aortic stenosis. In our patient, it was 138 ml per seconds. So it was less than this. So there was a problem we have facing. There is some kind of discordance. Now, why this is important? Because there is some work by Dr. Roxy Senior. He has looked at the aortic flow rate at baseline and after exercise, dobutamine stress exercise, and he has come out with a lot of information. How do this patient behave on exercise? But I'm not going to the details. I just wanted to mention that this is also available in the literature. Moving ahead with our case, apart from the aortic valve, this patient also had degenerative MAC, and once we interrogated, there was evidence of inflow stenosis, there was evidence of mitral regurgitation. And we tried to quantify. So the vena contracta was around 5, and with normal LV function, there was moderate mitral regurgitation. The inflow velocities peak by mean was 13/6, and she also had, she was in failure. She had also tricuspid regurgitation with a peak velocity around 3. So we were dealing with a patient of aortic stenosis with degenerative MAC, and these were the values. Because we had this patient came with a history of chest pain on exertion and breathlessness on exertions last 10 days, and a strain pattern which was giving you a pattern, we thought let's go for a cath. And I don't know why it is not working. So she had evidence of LAD mid 99% stenosis. The circ was normal. I don't know why it is not playing, and the RCA showed a mid 30%. So this was the most likely lesion for a recent sudden chest pain on exertion, and this was tackled on. But there is something more we have to identify in a patient of aortic stenosis, and I know that we'll be discussing more. So there is a role of CT calcium score in patient of aortic stenosis, and where does this CT calcium score comes into picture? So let me read with you that if you have a hemodynamically severe AS with a mean gradient of 40, an aortic valve area of less than 1, and if the patient is symptomatic, don't worry. Just immediately send this patient to either SAVR or TAVR, depending upon what is available. But if you have a mean velocity of less than 40 and aortic valve of less than 5 in our patient, which is discordant, then a role of calcium scoring is important. And remember the values. In males, anything more than 2000 AU, or in females, anything more than 1250 AU becomes a significant thing for this patient to be sent for aortic valve replacement. But if this is not being filled up, then you can follow this patients over a period of time. So the key is 2000 units in males and 1250 in females in a patient who have a discordant aortic valve stenosis assessment. Other patients, you can always follow this is there. But let me move ahead and tell you that there is something more to it. And so this patient had an angioplasty for the LAD, and the mitral regurgitation reduced after that. And we have given an option of a TAVR in this patient. But I wanted to move ahead about the role of any structural involvement. So this is an algorithm which is very, very complex, but it tells you that if you have a high flow aortic stenosis, immediately it is a class 1A indication for a patient for aortic valve replacement or a TAVI. But look at this third parameter. So if you're dealing with a low flow, low gradient aortic stenosis with the LV ejection fraction preserved, then there is a role of CT calcium score, which is important, but they are also looking at reduced longitudinal strain. So if you can identify a strain which is going down, then this patient should be considered for an aortic valve replacement or TAVI very early. So it is important that you should have a strain analysis of this patient. So I'm not having any information about what is the cutoff, but this all have to be looked at in this group of patients. So there is one more aspect which I wanted to tell you apart from this case, that we have been focusing more about severe aortic stenosis, but there is a recent work which came last 6 months back about the role of mild to moderate AS progression. And this work in JACC showed that severe AS, we don't have any problem. They progress. If you don't operate, 50% of these patients will have a 4-year mortality. But now the focus has also been there for mild AS and moderate AS, and there is a almost 30% progression of symptoms if they don't go for an early AVR or a TAVR. So now focus is coming towards mild aortic stenosis, or also moderate aortic stenosis, and there is an entity where the aortic, even if you have mild AS, look at the myocardium, and a lot of work has now come looking at the strain. Now people are focusing on looking at the mild AS because these patients also progress significantly if not treated well. Other issues which should be looked at is you should also have a assessment of other problems because they do coexist. Amyloidosis, I'm not going to details because the outcome is affected by this patient. So let me conclude that if you have a discordant gradient in a patient assessment of aortic stenosis, you have to do the measurements very carefully, because one of the most common problem of discordant gradient is error in measuring. Always identify all the measurements and adjust it to body surface area. Among patients with discordant gradient, look for aortic valve area, mean gradient, and stroke volume index. Remember this, flow doesn't provide any diagnostic information, but flow provides you prognosticate importance. So stroke volume index is important in every patient. The role of calcium scoring becomes utmost. Cutoff is 2000 in men and around 1200, 1250 in women. And intervention is recommended in all symptomatic patients, looking at both the aortic valve and the mitral valve. Couple of things about the, I know there are a few presentations about looking at structural. I will not be going to detail. Thank you so much.